Hello everyone! Magandang umaga po sa ating lahat. I am Dr. Riza Lorenzana, the Scientific Committee Co-Chair of akoparasabata 2021. Before we officially start Webinar 2, we request everyone to stand up from wherever you are, stretch a bit, and follow the steps to the akoparasabata 2021 Dance Challenge. So I'll demonstrate again the basic steps to our call sign. Okay. So that's ako, tayo, para, sa bata. Again, ako, tayo, para, sa bata. So game, let's do it together and let's watch the videos. So thank you very much for participating. And now, I will turn you over to the moderator of Ako Para sa Bata Webinar 2, Breaking Barriers in Child Protection Service, Training, and Research. She is the chairperson of the Women and Children Protection Unit of the Ospital ng Makati, a child protection coordinator at the Ocean Hospital and Medical Center, and the head of the Child Advocacy Unit in Makati Medical Center. Everyone, let us all welcome Dr. Geraldine Alcantara.
Thank you, Dr. Arizi. And hello, everybody. I am so happy to be here today in front of you, to be with all of you right now. Welcome to Webinar 2 of Ako Para sa Bata 2021, entitled Breaking Barriers in Child Protection, Service, Training, and Research. As mentioned earlier, we are in full capacity in our Zoom room. And as of the moment, we have 2,100 viewers of Ako Para sa Bata Facebook page. On behalf of Child Protection Network Foundation and UNICEF, we are deeply grateful for your support. The objective of today's webinar is to highlight programs to overcome the disruption caused by COVID-19 in the field of child protection. Specifically, it is to explain how telemedicine is used to increase the accessibility of child protection services and to discuss how the web-based child protection management information system improves case management. Third, to describe how the online training program on women and children protection increases the capacity of frontliners to respond to cases of child abuse and neglect. And fourth, to discuss how social workers can ensure permanent placement of children in residential care. We have 4 resource speakers, resource person, each discussing how we are addressing and breaking barriers in child protection. We will learn more about teleconsultation services or the Tele-CPU Center sa Barangay Project, the web-based child protection management information system, and the online training program on women and children protection, and the case management specifically involving children in residential care in just a bit. Our first resource person is a telemedicine director of the Child Protection Network Foundation. She is an ambulatory pediatrics fellow of the Philippine General Hospital, and also the pediatrician of the Ruth Foundation. To discuss updates on teleconsultation services, the Tele-CPU Center sa Barangay Project, let us give a warm welcome to Dr. Mary Ann Joy and Naria Maritana. Over to you, Dr. Mary Ann.
Since March 2020, when COVID-19 pandemic hit the Philippines, different quarantine protocols and restrictions were put into place, such as the enhanced community quarantine that limited mobility and hampered access to healthcare services. However, problems continue to exist apart from these two factors. Among the 114 Women and Child Protection Unit in 58 provinces across the country, there were 6,553 violence against children and 2,364 new cases of violence against women. The number of cases in 2020 dropped from 2019, but a lot of factors such as limited mobility and access to healthcare services could be behind this drop. Still, how many abused children could there be in their homes waiting for help to come? How many adolescents could still be feeling alone? Good morning. I am Marian Joynaria Maritana, the TeleCPU Project Officer, and today I'm going to share to you our TeleCPU Center sa Barangay project. For this session, here are the objectives I want you, our attendees, to achieve after the session. Let us start by looking back of our experience of the ECQ. How many of you got sick? How many of you experienced telemedicine? How did you avail of it? And what were your experiences with telemedicine? When COVID-19 pandemic hit our country, telemedicine became a very popular method in availing healthcare services. The DOH-UP Manila Telemedicine Practice Guidelines defined telemedicine as the practice of medicine by means of electronic and telecommunication technologies to deliver healthcare at a distance between a patient and a doctor. Another concept that further emerged during the COVID-19 pandemic is the concept of the Child Helpline. These are telephone-based services, SMS or call, that can be given in situations when there is restrained or limited physical interactions. They are free of charge, confidential, and accessible 24/7. Child Helpline will provide guidance, outlet for callers to report their concerns, and we even provide services such as legal and medical services. Child Helpline is different from hotlines. Telemedicine and Child Helpline already existed before the pandemic, but became more relevant during the pandemic. Both enable delivery and access to healthcare and child protection services possible despite the restrictions in mobility brought about by the pandemic, disasters, physical, and economic barriers. Since the Child Protection Unit offers varied services given by different professionals, we expanded telemedicine to teleconsultation. Teleconsultation involves rendering medical, social, psychological, and legal services at a distance between a doctor, a mental health professional, a social worker, police attorney at a distant site using technology such as audio and video calls. Realizing that not all Filipino children and families have smartphones or even load to purchase data for a teleconsult via video conferencing, the Child Network Protection together with UNICEF developed the TeleCPU Center sa Barangay project that involves creating TeleCPU centers, making serbisyo malapit sa bawat isa, at Child Helpline. This project aims to make the services of the Child Protection Unit accessible to each Filipino child despite the different challenges such as the pandemic. This project was developed through the collaborative efforts of the Child Protection Unit, Child Protection Network, UNICEF, and the local government units. As of October 2021, TeleCPU centers can be found in 13 cities, and we target to reach out 55 barangays. As of now, there are 37 functional TeleCPU centers in the Manila, Caloocan, Taguig, Parañaque, Las Piñas, Bacoor, Imus, Cavite, and other areas. The TeleCPU centers sa barangay components include manpower, facility, and logistics. So in terms of the logistics, the Child Protection Network and the UNICEF gave and donated the desktops, computers, Wi-Fis, and some of the smartphones. Here are some of our tele-CPU centers sa barangays showing the manpower or the staff, the logistics, and the facilities or the areas for the tele-CPU center. The manpower includes the barangay staff, Bausi BCPC, Kagawad, the tele-CPU team with our coordinators and IT support, and the Child Protection Unit staff or service providers. Each of the staff of the tele-CPU center and the Child Protection Unit underwent capacity building, such as online training on women and child protection, orientation and teleconsultation, and even technical training on the use of the Google account, specifically the Google Meets. Here are some of our photos during the online training sessions. For the facility, it should have good lighting and ventilation. It should be quiet, and privacy and safety should be ensured. Here are the areas or the facilities in some of our tele-CPU centers sa barangays. So, paano nga po ba makakatanggap ang isang bata ng teleconsultation services mula sa PGH-CPU? Tulad po ng nakagawian po nating proseso, dadalhin po muna ang bata sa CPU at titingnan po ito kung ito po ay nangangailangan ng child protection services. Pagkatapos po ay hingian siya ng pahintulot para sa check-up. Kung may pahintulot po, tuloy ang check-up. Pagkatapos po ng check-up ay pagplano sa mga kailangan pa po niyang serbisyo. Kung wala pong pahintulot, wala na pong check-up na magaganap. Kung nangangailangan po siya ng follow-up na teleconsultation, siya naman po ay hingian ng pahintulot para sa teleconsultation check-up. Hahanapan po siya ng malapit na tele-CPU center sa barangay or teleconsultation hub at saka po yung petsa at oras na akma sa lahat ng taong involved po dito. Tulad po ng sa CPU, kung wala pong check-up, so wala po siyang teleconsultation follow-up, or kung wala pong pahintulot sa teleconsultation po, wala pong teleconsultation na magaganap. In order to receive teleconsultation services, whether it would happen in the tele-CPU centers or in the comfort of their homes, a child should be a patient of the Child Protection Unit first. The CPU Child Helpline. So the CPU Child Helpline is like the other helplines that are telephone-based services, SMS or call, that are free of charge, confidential, and accessible during office hours. The CPU Child Helpline may offer advice and give information on what steps can be done pertaining to child protection concerns, and do coordination with the CPU service providers as needed. To our children and teens out there, flash in the screen is our child helpline phone number. So again, The Tele-CPU Center sa barangay ay isang proyekto ng CPN, UNICEF at ng mga barangay at bayan na naglalayong gawing mas malapit at mas madaling makamit ang mga serbisyo ng PGH-CPU sa pamamagitan ng computer at internet para sa mga batang may nais sabihin o tanungin tungkol sa mga nararanasang pang-aabuso. From April to September 2021, the Tele-CPU centers had 41 scheduled teleconsults, 38 successful teleconsults, and had served 23 patients. The Tele-CPU Center sa barangay works and continue to improve because of the interprofessional collaboration between the Child Protection Network and UNIT and UNICEF, policemen, doctors, mental health personnel, lawyers, and most importantly, the barangay and the local government unit staff. We all learn from and work with each other. Sa totoo lang po, napakarami ko pong natututunan mula sa social workers, UNICEF at komunidad. At marami tayong natutulungan dahil po kasama po natin sila. Remembering the 3 forms of help from Psikolohiyang Pilipino, Tele-CPU Center sa Barangay Project is more than just technology transfer of giving computers and logistics to the barangay staff. We aim toward community empowerment, which is a higher form of help. With the different online trainings, kamustahan, and even on-site visits wherein we get to know the community, wherein we get to know their ideas on how to make this project work and improve better, we continue to empower each other. Nakaka-inspire po ang ginagawa ng mga komunidad upang maabot po natin ang nilalayo ng Tele-CPU Center sa Barangay Project para po sa mga kabataan. Para po sa inyo, itong saludo ko po. So ngayon po, ini-encourage ko ang lahat na umattend po na Ako Para sa Bata webinar. Let us all play our role in protecting our Filipino children. In the future, we hope to see more Tele-CPU centers in Baguio, Cebu, and Davao, and we hope we could reach more areas and children in the future. Tele-CPU Center is for the Filipino children. We are here, ready to help you, our dear Filipino children and adolescents. To end, let us all continue to learn, to work with, and empower each other for the Filipino children. Ako para sa bata, tayo para sa bata. Maraming salamat po sa inyong serbisyo.
Thank you very much, Dr. Marian. Thank you for that enlightening lecture, and thank you CPN and UNICEF for reaching out. This only proves that no pandemic can stop us from reaching out to our children. Our next resource person is the Project Development Officer of and Database Administrator of Child Protection Network Foundation, Inc. She is currently finishing her master's in social development and specialization in policy and research practice at the Philippine Women's University. Ladies and gentlemen, let us hear from Ms. Ana Teresa Clemente.
Good day, everyone. I am Tere Clemente, and I will share with you an overview of the web-based Women and Children Protection Management Information System, or web-based WCPMISB administrative data. An electronic database is not new to the CPU-PGH or to other WCPUs, as it has been part of the case management process since 2002 using the standalone WCPMIS, which was developed primarily to improve the case and data management process. It was modified in 2005 and 2013, converting it into an HTML program and also to include the data sets on women. Ginamit din natin ito in 2014 as part of High-on Response by providing equipment, program, and training to 40 municipalities affected by the typhoon. And since 2015, in fact until now, this program is being shared with other WCPUs. Ginagamit na natin itong standalone WCPMIS for almost 2 decades. But remember that this is a standalone system, meaning the program is installed in a single device or computer, and all data are saved in the same device or into a server for those with local area network setup. At ang lahat ng mga equipment na to ay nasa loob ng WCPU physical space or unit na nasa loob din ng mga hospitals. Kaya naman, nung nagkaroon ng pandemic at nagkaroon ng mga lockdowns, the operations of the WCPUs were also affected, which according to the rapid assessment conducted by the DOH in May 2020, majority of the WCPUs reported to have lesser number of service hours, less number of personnel on duty. In fact, some units were converted to COVID area or facilities. These conditions also challenge the accessibility and utilization of standalone WCPMIS, including the data collections and processing. Therefore, what we need is a database system that is accessible, a system that is secured and confidential at all levels of access, a user-friendly system that can practically be used by anybody as much as how we use all sorts of social media programs, and a system that has the capability to share data with other databases or programs. And fortunately for us, that conditions gave us an opportunity to take advantage of technology and internet. And so, in 2021, we launched the new web-based database. This new web-based database is an administrative database or online system designed to gather real-time demographics of cases of violence against women and children, captured from its two main modules, the patient profile and the intervention module. A web-based system that ensures accessibility through internet browser using any devices that has an internet capability, such as desktop, laptop, Android phone or tablet, iOS phone or iPad, without worrying about compatibility of the program, unlike when using an app-based program. A web-based system that is secured at all levels of access, so all data are saved in the cloud. And the system does not permit direct access between WCPUs. For instance, kami sa CPN as super admin, hindi namin pwede makita yung raw data or details of patients ng ibang WCPUs, but we can capture the real-time demographics reports of all the WCPUs from the cloud server. This process guarantees that the details of patients of each WCPUs are secured. Furthermore, the system is secured by using two-level login process. So imagine ito yung parang wall that protects the system from all sorts of viruses and even from hackers. Within the WCPU, we also made sure that the data are protected na hindi ito mako-compromise due to human errors or accidentally ma-delete yung data by limiting the access of each users on particular modules based on the user's access rights. From all the lessons learned from the standalone program, ito yung pinaka-importante, that the web-based database is user-friendly, that it is easy to use, that the aim is to have it filled out in less than 10 minutes. Therefore, this program is designed na ang gagawin mo na lang is to select, click, and save. So all the data sets are listed in the drop-down menus, and the only detail that you have to type in the system is the patient's name. We put all possible multidisciplinary interventions and services in the system, from social, medical, mental health, developmental pedia, and legal interventions that would guide our service providers in developing an intervention plan that is responsive to the needs of our patients. There are other existing databases designed for management of GBV at marami pang klase ng ganitong database that other agencies are planning to develop. But the greatest goal sana is lahat itong database na to would have the capability to talk to each other or maging interoperable. That's why during the conceptualization, formulation, and development of the WCPMIS web-based database, we also looked into the datasets of BAUSI registry system of the DOH and the datasets from the harmonized data form on BAU developed by the PCW, and adapted and applied the common datasets into our system. So later on, when we talked about merging of data or interoperability of the database, at least it is already compatible with other datasets. Right now, this web-based database is being used by more than 60 WCPUs nationwide. At gaano ito ka-effective at gaano ito ka-user-friendly, let's hear it from the WCPUs of Baguio General Hospital and Medical Center and Vicente Soto Memorial Medical Center.
Naimbag nga aldaw kadatayo amin may sa akablaaw agapu iti Baguio General Hospital Medical Center Women Children Protection Unit. So, with the existence of WCPMIS, we can easily monitor and track the scheduled intervention of the client and their family. Also, the system is simplified, but important information was not compromised. And lastly, the system provides a readily available statistical data needed by the unit. Therefore, WCPMIS is very helpful for us. Thank you.
Before WCPMIS was introduced, patients' data was manually charted and stored, which is space and time consuming. The WCPMIS is a web-based women and children protection management information system. It is quick, easy, user-friendly, and data are stored safely and can be easily accessed. We offer medical, social, and psychological services to abused women and children, survivors of violence. And each patient's information and intervention done are entered individually. Updates of these patients are facilitated quickly because of its accessibility. That is why we are grateful that our center is now using the WCPMI system.
Thank you, Annie Ofoob and Pink Center Productions. Now, lastly, another important feature of this web-based database is it provides real-time demographics of cases of violence against women and children. But when we look at this real-time data, we are not just looking at numbers. We are also looking at the real-time stories of abuse and neglect. Thus, this report serves as an accurate picture of what is happening in terms of BAUSI real time. Unlike before that we need at least 6 months to collect and process the data. And so we hope that the reports generated from the system would aid us in developing a program or policy aligned to the needs of the victim survivors of abuse. And that's it for the web-based database. Thank you all for listening.
Thank you very much, Ms. Tere. Thank you very much for that calm and cool presentation. Okay, only Ms. Tere can do that. I enjoyed reviewing the history of WCPMIS with you. And personally, I am not a very techie person. I am a super digital immigrant. But I am very happy because we can use this system because it is truly accessible, user-friendly, and it has secured. It is secured against human errors, which I always have. So thank you very much for that. Before we go to our third speaker, we just want to inform everyone that as of the moment, we have 2,900 Facebook viewers. All right. Next, we We move on to training. Our resource person is the training director of the Child Protection Network Foundation. She is a medical specialist too at the Philippine General Hospital Child Protection Unit, a diplomate of the Philippine Pediatrics Society and the Philippine Ambulatory Pediatrics Association. She has also a diploma in the health professions education from the National Teacher Training Center for Health Professions at the University of the Philippines to present the online training program on the women and children protection. Let us all learn from Dr. Melissa Joyce Rambuanga.
In early 2020, because of one virus, the world and our lives were placed on hold. Schools closed, businesses stopped, people locked in their homes. But abuse still continued. Violence against children and women continued to increase, akin to the surge of the COVID-19 virus. Seeing an increase in the number of abused women and children, especially cases of online sexual abuse and exploitation. Of course, as women and children advocates, we cannot just let this silent epidemic continue. What can we do? Seeing the important role that the local government units have played in the delivery of services during the height of the pandemic response, we felt that it is also important to tap them in making sure that women and children protection services continue in the communities. However, it is also important to prepare them for this. Hence, the Child Protection Network, in partnership with different organizations like UNFPA and UNICEF, have developed and continue to develop training programs to build the capacities of our counterparts in the community. This is not really new. CPN has been doing this since the pre-pandemic period. The challenge lies in translating these face-to-face training programs to an online one that can reach students from all over the country. Fortunately, the lockdowns also provided us with sufficient time to prepare for the transitioning, and also with the help of our partners, such training programs have come and are coming into fruition. One of the first programs that we implemented was the online certificate course on women and children protection specialty training. This training was geared towards preparing social workers to be child protection specialists, since they are frontliners in the service provision in the community. There were 2 batches with a total of 62 graduates. The training lasted for about 5 months each, with a mix of self-paced modular learning, small group discussions, and case supervision as a culminating requirement for the students. And with a project to install tele-CPU hubs in the barangays for easier access of patients to online CPU services, partner barangay personnel were also given an orientation to child protection through this 5-day course, with synchronized sessions of lectures and group discussions. This training was implemented in 3 batches with a total of 153 graduates. In early 2021, a partnership with the UP National Teacher Training Center for the Health Professions was forged in formally transitioning the 3 core training programs of the Child Protection Network to an online one, in order to ensure that the education of child protection advocates and future specialists continue despite the pandemic. In the restructured training, a student undergoes a step-by-step program from 4 hours training to MDT or multidisciplinary team training, and to the women and children specialty training, with each course serving as a requirement for the next training level. A course site has been developed where students can access their learning modules with videos and reading materials, as well as quizzes and other learning activities and resources. The first level of the ladderized training program is the 4 R's training, which focuses on recognizing, reporting, recording, and referring cases of abuse. It has 2 self-instructional modules that students must finish within 1 month. It should also be noted that the course is fully asynchronous, meaning it can run on its own through the course site. For the first batch of enrollees, there were 111 graduates who were recognized last September 9 and even congratulated by the Chancellor of UP Manila, since this is a project of CPN and UP entity CHP. The next level is the multidisciplinary team training, open to physicians, social workers, and police officer graduates of the 4 R's. It has asynchronous and synchronous sessions for its 4 training modules that the students must finish within 6 weeks. This is still ongoing, but we are looking forward to graduating all the remaining students. These are the modules covered by the MDT training, and as you can see, it builds up from knowledge to skills to actual practice, so that by the time they enter the next level, the Women and Children Protection Specialty Training, they will be ready for the more intensive discussion of the lessons from previous courses, as well as additional special topics, and also for their 2-week on-site practicum, when the conditions have already improved. So far, the feedback for the trainings we have conducted have been favorable, and the students appreciate all the learning they have experienced. Of course, there were some difficulties with internet connectivity, but with the perseverance of the students, they still managed to finish their courses. If knowledge is power, then knowledge comes with great responsibility. Let us use what we know for a better future for our children. Thank you.
Welcome everyone. I would like to mention especially our partners, Professor Erlene Sana, Professor Melf Atienza, of course, Attorney Katrina Legarda and Judge Ami Abellano, our UNFPA partners, Amy Santos, I'm sure you're here, and representatives from the ICTSI Foundation, from the UP Manila IMS, Geoffrey Solano and Dong Calmada. It's really a pleasure working for this wonderful team that enabled us to launch this first online training program on women and child protection.
Itong bata doon sa foster parent. Kung malalicense siya as foster parent.
Opo, parang may update po si Sir Mark regarding din sa kung license na po ba yung
wala silang concept or mindset na may gagawing masama sa kanila. So, parang alam mo yun, ang worry ko dito, baka manormalize sa behavior niya yung naging experience niya.
which were very relevant and faithful to the main objective of the course. All the lecturers were very knowledgeable and delivered information emphatically. Reference materials were shared which added further insights into the matter. I have learned so much.
As a police officer, this training is very relevant and useful in our daily endeavor, especially we are assigned in the lower units and usually we encounter this kind of problem. This training is very interesting because we gain more knowledge on how to handle the abused victims, and aside from that, the speakers are experts on their assigned topics. I am thankful to the coordinators of these trainings for inviting me as one of the participants, even though I encountered problems due to the poor internet connection and a hectic schedule due to our workload during this time of pandemic, but still managed to request and in order to attend the synchronous and able to answer the module. Thank you.
Ha? Ayun ta. Yung time, nakakasagot naman kayo lahat ah. 30 seconds po yun, which is the usual time for a multiple choice questions.
Promise po, pag ginawa niyo po yung module, sinimulan niyo, matatapos niyo kaagad, isang linggo lang.
Your tasks are crucial now, more than ever, with the resurgence of COVID cases involving families, women, and children. Settings like quarantine measures that restrict the victims to places with the perpetrators of abuse and violence and limit their ability to report cases are unhealthy and hostile for the victims. Timely, urgent, and appropriate interventions are necessary. Such interventions entail the availability of adequately trained and competent personnel. It is the prayer of every parent, sister, brother, and UP Manila constituent that this training will succeed in restoring and strengthening services and personnel who will protect, heal, and nurture our country's women and children.
All right. Thank you very much, Dr. Ramel, for your presentation. It is indeed insightful. It only proves once again that the barriers set by the pandemic is not strong enough for us not to break, because we are coming in stronger than it. Okay, and to prove it, we have 3,016 viewers on Facebook as of the moment. Thank you, and we go on to the last but not the least speaker for this morning. It is good to know how we are innovating and breaking barriers in order to overcome disruptions caused by the COVID-19 in the field of child protection. Our last resource person for today is the Social Welfare Officer 5 and Officer in Charge Deputy Program Manager for operations of the Pantawid Pamilyang Pilipino program of the National Program Management Office of the Department of Social Welfare and Development. She specializes in case management and child welfare and development. Her subspecialty includes child protection services, residential care services, and alternative parental care services. To present the case management on children in residential care, ensuring children's permanent placement, let us welcome Ms. Rosalie D. Dagulo. Good morning, Ma'am Rosalie. Over to you.
I am Rosalie Dobles Dagulo, and I am very honored to be with you today to present a part of my study entitled Case Management on Children in Residential Care, Ensuring Children's Permanent Placement. This study employed thematic analysis and used focus group discussion as a data collection method. I did this research only this September this year, in pursuit of the master's degree in social work in Miriam College. And I engaged 11 registered social workers in this study, each one representing one of the 11 residential care facilities run by the DSWD nationwide, serving 0 to 6 years old children who were abandoned, neglected, or surrendered by their parents. As a background, we know that every child has inherent rights that have to be fulfilled. The parents provide for the needs of their children and fulfill their rights by performing parental duties and obligations. However, there are situations when children are separated from their parents due to neglect, abandonment, or when they are committed voluntarily by parents to the state, or when children are orphaned. Extended separation from parents, which happens when children are in out-of-home care, has detrimental effects on the children's physical and emotional well-being and takes its toll until their adult life. Data shows that 3,261 young children served by the DSWD's 11 RSCCs from 2016 to 2019, with an average of 815 children served per year. The average length of stay of children in RSCC from 2017 to 2019 was about 2 to 5 years. This significant period of time has already deprived these children of a family life. Being away from parents, these crucial years of growth and development. To manage the cases of these children in residential care facilities, the DSWD issued a number of memorandum circulars and administrative orders that guide the social workers in case management. In particular, there is AO number 11, series of 2012, which we popularly know as the CDCLA guidelines, or the certification declaring the child legally available for adoption. But even with these guidelines, delays have been observed in the return of children to their parents or in giving them alternative childcare. Given this scenario, my aims as a researcher is one, to describe how social workers undertake case management for the permanent placement of children during COVID-19 pandemic. Two, discuss the facilitating and hindering factors in the permanent placement of children. And three, provide recommendations to ensure permanent placement of children. First off, let me define to you three important concepts in this study. Case management, permanence, and permanence planning. For case management, this is a process to plan, seek, advocate for, and monitor services from different social services or healthcare organizations and staff on behalf of the client. This enables the social worker in an organization or different organizations to coordinate their efforts to serve a given client through professional teamwork, thus expanding the range of needed services offered to the client. Through case management, problems arising from fragmentation of services, staff turnover, and inadequate coordination among providers are given solutions. What is permanence? If you would note in my title, I used the term permanence placement rather than permanent placement. Permanence is a framework of emotional, physical, and legal conditions that gives a child a sense of security, continuity, commitment, and identity. Children require consistency and continuity of care in order to provide them with a foundation from which their physical, emotional, and developmental needs can be fully met, allowing them to reach their full potential. So what is permanency planning, on the other hand? It is the process of assessing and preparing a child for long-term care when the child is in out-of-home placement, such as kinship, foster care, or institution. So these placement types are temporary in nature. And reunification with the birth parents is the primary option of permanence, which may be used, like I've said, permanence placement rather than permanent placement. Now let's go to the key findings of the study. First, the findings show that reunification of the child with the parents is the top priority permanence option in all actions of the social worker on the case of every child that is referred for residential care. That means only when reunification is not possible, the social worker's next option may be adoption, domestic or intercountry. Then permanence planning is embedded in the case management process undertaken by the social workers. And the social workers undertake careful steps of case management where permanence planning is integrated. In the next slide, I will be showing to you a diagram that shows the case management system in the residential care facilities. So here you would note that the process begins with an intake assessment. A pre-admission conference is the most common method of gathering information to determine whether residential care is necessary. All participants in this research believe that residential care is the last resort, and as much as possible, the child should not be separated from the parents. So you would note in the bars extending from end to end, you would see their feedback, case conference, and referral, which the social workers do in case management throughout the process, anytime and in any step of the process of case management. And in this process, the social worker coordinates with different entities like the local government units, the courts, the police, and also with NGOs or civil society organizations. The LSWDO's role in case management is very crucial here. The LSWDOs are the source of referral, but to a large extent, they are also engaged in many tasks in case management, like when social workers refer to them the parents that are for services, for support services, so that they will be able to accommodate again or have the children back to their care and custody. So it is important that a parenting capability assessment is done by the LGU social worker so that the social worker in residential care can decide whether a child can be reunified with the parents. The LSWDOs also monitor families to whom children have been returned. So you would note there in the blue panel there at the end of the diagram, that is a follow-up and aftercare. The LSWDO's role is very crucial because when the children are returned to the care and custody of their own parents, they are monitored by the LGU social workers. And after about three post-placement reports that the social workers in residential care facility requests, these are used to determine and assess whether the reunification is doing good, and therefore the child will be maintained in the care and custody of the parents. So the duration of case management varies. The shortest duration is 6 months, and the longest is 3 years. Cases of children with disability, like those with cerebral palsy, with global developmental delay, took about 4 to 5 years before discharge, and those that have severe conditions are still with the facilities until this time. There is a case that took 7 years before the child was discharged due to a court case. In the next slides, I will be presenting to you the facilitating and the hindering factors, which I categorize into 5 levels: systems level, organizational, worker level, case level, and child and family level. For the systems level, I will be showing you 2 slides. The facilitating factors include presence of the following: laws mandating and supporting the permanence placement of children, clear policies and guidelines on the turnaround time for the declaration of children as legally available for adoption. And here you will be noting in red text, social media and other online applications and platforms for communication, which I attribute to COVID-19 concerns. For the hindering factors, there is absence of the following: define programs and services for families of children, including the parenting capability assessment system, a written policy and procedures in contingency or concurrent planning for permanence, and tool in assessing reunification probability. Again, related to COVID-19, there is poor internet connection or signal. Next slide, a continuation for the systems level. Facilitating factors also include support of barangay, police, LSWDO in the process of locating the parents, securing records or documents. And related to COVID-19, existence of functional telemedicine. You have heard earlier our resource person talking about telemedicine for health and medical concerns and treatment of children. And for the hindering factors, all attributed to COVID-19, varying guidelines and policies in LGUs on health protocols that made movement and securing records difficult. COVID-19 health protocols led to longer period of waiting for parenting capability assessment and post-placement reports. Inadequate system of action and feedbacking on requests for assessment, reports of documents when personnel of LGUs and other offices are on work from home. Next slide will be on organizational level, and the facilitating factors include presence of personnel that provide technical assistance to the social worker in the residential care facility. These personnel are usually in the field office and the central office, giving assistance in case management. Open communication between and among units and offices in the agency. And related to COVID-19, presence of a functional vehicle, that is the presence of an ambulance that is not restricted to move around during community quarantine and health protocols. For the hindering factors, we have the fast turnover of social workers due to lack of security of tenure, and most LSWDOs are burdened with heavy caseloads and assignments. For the next slide, this is at the worker level. Facilitating factors include, if you would note, characteristics, principles, and values of the social worker are all facilitating the permanence placement of children. And this includes the belief of the social workers that residential care should be the last resort for children. The openness of social worker to seek and receive advice or opinion from co-workers from another unit, so there's no sense of competition. They prioritize reunification over other options for permanence placement. They have a sense of accountability for the child to be with a family, because that is a basic right of the child, and has a network of resources for referral of children for services. For the hindering factors under worker level, related to the organizational concerns, many of the social workers are holding the COS or cost of service MOA item, memo of agreement, and this means that they have a contract that is temporary, and anytime they could be terminated due to lack of funds or due to the end of the project. There is linear planning. This means that plans for other options for permanence are taken by the social workers only after reunification fails. And there are delays in accomplishing tasks by the social workers when they are inflicted with COVID-19 or become close contact to COVID positive persons. So the next slide is on the case level. The facilitating factor, they only identified one, which is the issuance of CDCLAA. That means if a child is issued with this certification, it is facilitating the permanence placement of children, and that for the purpose is for adoption. And the hindering factors include sibling group, case of sexual abuse, cases with court case, as I have mentioned earlier, the one with 7 years stay in the residential care facility. Children with disability is also a hindering factor. And for the child and family level, for facilitating factors, child without disability, children who are below 2 years old, and for the hindering factors, has a disability, older child, and that means that older child means 3 years old and above. Family has social, economic, or domestic issues, unknown parents or background, child is victim of sexual abuse, and related to COVID-19, lack of gadget or load for phone, computer use, and internet connection. So in the next slide, given these findings, these are my recommendations. I will be presenting to you the first 6 recommendations that are specific to COVID-19 concerns. First, draft and issue a policy on the use of social media and other online applications in case management, ensuring ethical confidentiality and data privacy protocols. Currently, the DSWD has an effort to develop an electronic case management system, and this policy is very useful that could be integrated into that system. Second, the LGUs, in collaboration with the residential care facility, to create a mechanism for families who do not have gadgets and access to internet connectivity to facilitate communication. Third, intensify the information dissemination and advocacy on the policy and procedures on CDCLAA for agencies like the PNP, the Civil Registrar's Office, and the LGUs. This is very important so that the process of securing of records or documents from their offices will be efficient, organized, and systematic, thereby avoiding delays. Fourth, address the interzonal policies and guidelines on mobility, taking action on requests for assessment and documents, provision of vehicles and permits for social workers to facilitate mobility amidst COVID-19 restrictions. Services should not be disrupted. Fifth, residential care facilities and LGUs to create a response and support team in case management to take the place of social workers who are under quarantine or isolation. And sixth, integrate the telemedicine services in the regular programs and services in residential care. The next slides, I will be showing to you the other recommendations. And this is the 7th recommendation, review the procedures of the CDCLAA taking into consideration the following. Integration of clear parameters in the current guidelines, in the planning and deciding for reunification with birth parents. This is because the current guidelines are more pronounced in terms of adoption. Indicate a direct and clear policy on permanence and concurrent or contingency planning so that the process is not linear, but will be undertaken simultaneously with the reunification efforts, thus shorten the process. The 8th recommendation I'm making, evaluate the policies and procedures on the following. On the foundling children, expedite the processing of children's certificate of foundling necessary in filing the petition for adoption. Issuance of birth certificate to all persons who have unknown parents is strongly recommended. Children that are not adopted due to age and disability will grow with only the foundling certificate and will not fulfill their right to an identity and nationality. If you would note, a foundling certificate doesn't indicate the parents of the children, and it also doesn't indicate the nationality of the child. Another recommendation, social workers to be allowed in securing authenticated copy of birth certificate and other relevant civil registration records on behalf of their client. This will facilitate the process of CDCLAA and alternative child care placement, and cancellation of simulated birth certificate simultaneously with the process of CDCLAA. And this is expressed very openly by our participants in the focus group discussion. And the last of the other recommendations, the LGUs to develop or improve, if there is any, and sustain family support services like economic, psychosocial services, parenting skills development, among others, for the birth families of children that are in the care of residential care facilities or in foster care, so that interventions are done with the children and also interventions are done with the families so that reunification will be facilitated. And we believe that family support services are an integral part of permanence planning, which should be used to enable children to remain with their birth parents. 10, review current programs and design alternative childcare programs for children with disability that promote stable, long-term, and sustainable support. And lastly, but not the least, employ and train more social workers at the local level to manage cases and provide intervention to families of children towards reunification. So that is the end of my presentation. Thank you very much for listening.
Thank you, Ma'am Sally. Thank you very much for that lecture. It just gave us more direction. Kung baga sa ways, madami palang alternative routes to our destination, and that is to protect our children. So I hope that you have taken as much knowledge as you can, as I did. And so we go to the question and answer portion. Are we ready? So may I call on our resource persons to join me in the Zoom space. Dr. Marian, there you go. Hi, Dr. Marian. Miss Tere, hello. May we call on Miss Dr. Ramel and Ma'am Sally? There you go. Hello po. Thank you very much for your lectures. Ang dami na pong questions, and para lang Miss Universe ito, sinong uunahin natin? So the first question that came in is for Dr. Marian. Madaming actually questions. How do we set up a tele-CPU in our barangay? Do we need trainings or a MOA with a child protection network? Dr. Marian?
Good morning po to everyone. So, in setting up a tele-CPU po in your barangay, it is best po to coordinate with the Child Protection Network. So, there will always be a memorandum of agreement because it will state the duties and responsibilities po of the barangay and the Child Protection Network. At the same time din po, we also need training. And also, we have minimum requirements for the facilities and the logistics that will be needed in setting up your barangay. So you can visit po our Child Protection Network .org po na page po in the internet.
Thank you, Dr. Marian. I hope that answers maybe 3 or 4 questions in the Q&A chat box. Everyone's interested dun sa teleconsult natin. Now, our next question will be for Mr. Re. Mr. Re, is the database accessible to the public?
Okay, so right now, yung WCPU database natin is for WCPU pa lang as of now. But as I mentioned earlier, di ba, pinag-uusapan natin yung interoperability ng system, which means na itong database talaga is continue nating i-develop, and we'll see kung hanggang saan natin kayang ma-streamline yung program, hanggang saang agency yung kaya natin maabot. Pero as of now, yun lang muna. Nasa WCPU lang muna tayo.
Okay, thank you. Thank you, Mr. Re. And now our next question will be for Dr. Amel. How can we enroll to the online training programs? Dr. Amel?
Just have to coordinate with the Child Protection Network, and there's also an enrollment site, enrollment link posted on our website, www.childprotectionnetwork.org. I will paste it in the chat box so that you can access it anytime po.
Thank you. So With the questions, ang answer po ay you have to coordinate with the Child Protection Network for both teleconsult, and the online training program. So we have to coordinate with the Child Protection Network, and yan ang expertise po ni Mr. Re. Siya po ang aming point person palagi. Mr. Re, help us please. And Ma'am Sally, madami rin pong questions for you. Teka, nasa na nga pa yun? Okay. For Ma'am Sally, please elaborate the tool in assessing reunification probability as a hindering factor.
Yung reunification probability, actually, meron tayong iba-ibang tools na ginagamit ngayon, no? For one, the DSWD Program Management Bureau actually issued a template para malaman, no, kung yung bata ay pwedeng ibalik sa parents through a parenting capability assessment. No, so ito yung sinasabi natin na probability of reunification. Pero ang naging feedback ng mga social workers sa LGUs according to our participants in the FGD, masyadong mahaba, no, and some of the areas in the template may not be so useful for them. And what they did is that just pick up those areas of the tool that could be used, no, for assessment. Given that, as I have presented, masyadong overburdened sila in terms of their assignments and caseloads. And what we need to do is really to come up with a simple tool, but very efficient and effective in terms of gathering information to assess whether a child could be reunified with the parents. So far, sa aking literature review, wala pa akong nakita na Philippine-based na ganung tool na ginagamit natin sa ngayon. There are attempts, and I hope there will be a specific effort, no, of particularly of the DSWD and the LGUs, no, could also do that as well, so that magkaroon tayo ng tool na magagamit natin. Probability, the high probability or low probability, pwede ba itong ibalik o hindi sa parents, yun yung dapat niyang ma-measure, yung tool na yun. So far, there is still inadequate tools for us to use for that purpose, and we hope to have that soon, given the efforts of developing an electronic case management system, that this could be integrated.
Okay, I think we have the same question also in Facebook. Is there any updated or issued policy concerning the reintegration of children considering the implemented safety measures? Parang I think you answered that.
Yeah, right. Oo. So yun din siya, yung reintegration kasi ng bata. Kasi sa ngayon, marami tayong policies, no, marami tayong batas, no, talking about adoption, foster care, no, both domestic and intercountry. Meron tayong mga batas, policies on the institutionalization actually. No, may ginawang policy ang DSWD through the Policy Development and Program Bureau, no, sa central office on the institutionalization. But it has to really integrate in it yung purpose of reunification, valuing the return of the child to the parents whenever possible. So yun ang number one sa lahat. Saka pa lang tayong magkagaroon ng planning. Although in my research, ang aking nire-recommend simultaneous planning, no? Habang nagkakaroon ng reunification efforts of the child with the family, meron ka pa rin tinitingnan ng ibang anggulo na tinatawag na contingency or concurrent planning in the literature, para sabay mo silang titingnan kasi baka may nakikita kang mga areas telling you that reunification may not really work out. So meron ka na kagad antabay na plano for a possible alternative placement for the child. So, pero number one talaga sa ating tool, sa ating mindset, sa ating framework is the reunification, the return of the child with the parents.
Thank you, Ma'am Sally. That's very clear. Loud and clear po yan. Okay, for Dr. Marian again. Is it possible to post directory of barangay teleconsult at tele-CPU so that we can there is access for the programs?
Okay po. So, we have a directory po of the tele-CPU centers. So, we're finalizing it po. So, this month, we can release po the tele-CPU centers. But I would also like to remind po everyone that before using po the tele-CPU centers, we have the patient po should be brought to the child protection unit first. However, they can also go to the tele-CPU centers if they have other questions. For now, if you have any questions regarding child protection po, they can always reach our child helpline phone number po.
So Dr. Marian, dapat registered muna sila sa WCPU of their locality, diba? Of their municipality.
Yes.
Bago sila maka-access for teleconsult, tele-CPU sa barangays.
Sa ngayon po, CPU, PGH pa lang po yung mayroon na access po with the tele-CPU centers po.
Okay, thank you, Dr. Marian. Dr. Mel, clamor for training for teachers and guidance counselors. Meron po ba daw yun?
Actually, the 4 hours training is open to everyone who's interested in child protection or in topics in safekeeping children. So, open naman po yun for teachers, for social workers, for guidance counselors, even for barangay personnel. So, open po siya. And as of now, free pa rin po siya. So, register lang po through the website. So, yan. Coordinate with us and yan po, ma-enroll po kayo dun sa course. Bali, yung next na enrollment na training period is November 1 to November 30 and then December 1 to December 30. December 30. So, yan. Enroll
Thank
po.
you, Dr. Mel. Thank you, Mr. Re. Question daw, how will they apply? Yung hospital nila, how will they apply to have a WCPMIS?
So, katulad in connection doon sa diniscuss ni Dr. Mel, so sana mag-training muna sila and then once established na yung WCPU doon sa hospital nila, then that's the only time as of now na magkakaroon sila ng WCPMIS. Kasi yung WCPMIS is part of the support ng CPN to the existing WCPUs and doon sa mga magtatayo pa or mag-establish pa ng mga WCPUs. So training, then WCPMIS.
Thank you. So training po muna, pwede pong mag-register sa website ng CPN and then you just click the training there and then all the training programs will come out. And as discussed earlier, ladderized. So we all start with the 4 hours. Okay. Ma'am Sally from Facebook. Okay, for Ma'am Sally, working with an LGUs can be challenging because of their limitation on most areas such as resources, not mentioning the commitment they have for their constituents. What could you recommend with LGUs which don't respond appropriately to the aftercare program?
Aha! Challenging yung tanong.
Opo.
Oo, kasi actually, yan yung isa nating findings talaga. Kasi siguro ang makikita natin, no, ng hindi para maliitin yung kakayanan ng LGUs. Halos sa kanila kasi nagko-converge lahat. No? Kasi sila yung mayroong jurisdiction dun sa kanilang constituents. So the clients, the children that are in the care of residential care facilities will go back to communities that are within the coverage of local government units. So talagang malaki yung responsibility, no, for the LGUs. Now, what we do is the social workers that participate in the focus group discussion, ang talagang una sa lahat is they maintain a very good working relationship with their local government units. So isa yon, no? Kaya dapat dito wala kang kaaway dito, lahat kaibigan mo, no? And that is a very very basic principle in networking, no? You have to have a good relationship with your partners. And second, if they cannot do the task, actually yung ibang social workers na nag-participate, sabi nga nila the child's name is today, and therefore the child could not wait. So ang ginagawa nila, pag talagang hindi maka-respond si social worker ng LGU, they also tap other social workers in the community-based setting. Doon nila nire-request, no, na gawin yung like for example the parenting capability assessment, and some of the social workers that participated, they themselves do the parenting capability assessment. One participant in the FGD said that 3 times na siyang gumawa ng parenting capability assessment dahil hindi makagawa si local government unit. Hanggat maaari, we want the LGUs to really take part, no, in the case management, because after all, the children will go back to their communities. They will be the ones monitoring the families that have these children in their care and custody. So kaya nakita sa recommendations kanina na hanggat maaari sana makapagdagdag ng social workers sa local government units, because hindi lang case management ang ginagawa nila, may iba pang mga proyekto, alam natin yon, no? And they are under the supervision of the city or municipal mayors, no? So kailangan natin silang maintindihan, but at the same time, what the DSWD is doing is really providing technical assistance if they need this, no, so that they will be able to manage the cases under their jurisdiction. But that's number one, a very good relationship, and if they cannot do so, then we could help, no, in doing the task. Although talagang mabigat yun, actually mabigat.
Thank you, Ma'am Sally. I love that line that you just gave us, that the child's name is today and that she cannot or he cannot wait. Maraming salamat for that. I will keep that in mind and in my heart. A question from Dr. Batino Bakiran for Dr. Marian. In cases of telemedicine between residents and the patients from the community, how do you protect your health workers who will be seeing patients face to face?
Can I ask
again
the question?
Kaya nga, pero in cases of telemedicine between residents and patients from the community, how do you protect your health workers who will be seeing patients face to face?
Okay po.
Parang
I think there are 2 situations po dito. How can we protect healthcare workers who use telemedicine and also who use face-to-face po?
Face-to-face, yes, I think.
So I think po, in order to protect po those healthcare workers who uses telemedicine po, we always have to train also. So for among pediatricians, we have these guidelines for telemedicine use. And every time the resident is going to use telemedicine po, there should always be a consultant who supervises them po. Or at least po, they have underwent a training on telemedicine on how to do it the proper ways po. For other professionals, we have the DOH UP Manila Telemedicine Practice Guidelines that was issued in 2020. So we can review that and we can follow the guidelines. As of now po, I think there are still no formal or legal laws on telemedicine. But I think as long as we go with the guidelines po, then we can always save ourselves po from other legal issues. At the same time, very important po informed consent. So every time you get teleconsultation or telemedicine po, we should have an informed consent. And the benefits, the risks, and the limitations po of teleconsultation and telemedicine should be properly explained to the patient and the caregiver if the patient is pediatric population. Now po, not all cases is okay for telemedicine or teleconsultation. There will be times that this patient will be asked to be brought for a face-to-face consultation. For face-to-face consultation, in order to protect po healthcare workers, we should just follow po the protocols that the DOH and our own hospitals put into place to prevent infection, not only for COVID-19, but the other infectious diseases also. So as long as we follow po protocols, I think each of us, each healthcare worker will be safe po from any harm.
Thanks, Dr. Marian. That's well explained. So yung apat dapat, yung promote, we have to protect ourselves. Okay. I think we have time for one last question. And this question will go to Mr. Re. Mr. Re. How are the demographics in the WCPMIS database? I guess this is kulang yung question na shared to the other agencies, or can we share it to the other agencies?
Okay. So yung web-based database, nakakakuha tayo din ng real-time data, and so the data or yung process data nakapost na siya sa website natin. So not really real-time kasi parang at least updated yung data na nandoon sa website na pwede nilang kunin anytime. Yung website is www.childprotectionnetwork.org. Okay. So lahat ng mga information, pati yung sa training, nandoon, same website.
Basta dapat nandun lang sila dun sa system, dun sa network, diba? So, and before we can do all of that, we all have to undergo training. And it all starts with the 4 Rs. And also communicating and coordinating with the Child Protection Network. Thank you very much to all our speakers. I think unfortunately, that's the only time we have right now. Thank you very much, Dr. Naria Maritana, Ms. Clemente, Dr. Rambuanga, and Ms. Dagulo for sharing ways of breaking barriers in your in the field of child protection. And before we let you go, can you please, can we request words of wisdom from you guys to share with us one practical advice on resilience? Dr. Marian, go ahead po.
For me po, para po sa akin, there will be more challenges po in the future. But with innovation and collaboration po with professionals and communities, we can invent ways po to overcome them, like the one that we invented po, the Tele-CPU Center sa Barangay Project. So let's innovate, collaborate, and invent ways po to overcome our challenges. Thank you po.
Thank you, Dr. Marian. Mr. Re, your words on resilience?
I think just for now, let's continue whatever we have right now or kung ano yung mga ginagawa natin right now. In particular, like dito sa WCPMIS, let's continue to use the program. We improved as we use it. So, yun lang, dire-diretso lang whatever we have.
Maraming salamat. Dr. Ramel?
Protecting women and children may be a daunting task. So it is a big battle that we have to win. And the best way to arm ourselves for that battle is through knowledge. And of course, compassion for what we do. So, yun. Enroll na po kayo.
Thank you, Dr. Ramel. And Ma'am Sally?
Talk to somebody. You have somebody, a buddy, no? Napakalaking factor nung meron kang nakakausap kapag nasa gitna ka ng crisis or ng conflict. And also, do not resist crisis or conflict because in those times, very good ideas arise. So, face it, acknowledge it, and think of ways to address it.
Thank you. And we are not alone because we all have each other.
Yes.
Thank you very much, everyone. Thank you very much to our beautiful, lovely speakers who joined us this morning. Thank you for enlightening us. And thank you thank you to the active participants as well. Okay, tayo, para sa bata. Maraming salamat po and good day everyone.